so much for joining us here today. Um, the session that we have today is called Geriatrics and HIV, Frailty, Falls, Cognition, and Functional Decline. I'm very happy to have you all join us today. Before we go into the session, I want to acknowledge that this session is taking place on the traditional territories of many Indigenous peoples, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Wendat peoples. We recognize that Indigenous communities continue to experience the ongoing impacts of colonialism, including inequities in health, mental health, housing, and access to care as they age. As we come together to discuss HIV, aging, frailty, cognition, and functional decline, we do so with a commitment to equity, dignity, and culturally responsive care for all communities. Just a couple of housekeeping items before we get started. This session is being recorded and will be available to everyone afterwards. We will not be recording the question and answer period. Without further ado, I'd like to go ahead and introduce our speakers for today. We have Dr. Luxey Sirisegaram, who is a geriatrician and assistant professor at the University of Toronto with clinical and research expertise in aging, HIV, frailty, and models of care for older adults. She completed medical school at the University of Calgary, followed by residency training in internal medicine and fellowship training in geriatric medicine at Western University. And then she later completed a Master of Applied Science in Patient Safety and Healthcare Quality at Johns Hopkins University. She also co-founded a novel Aging While Living with HIV clinic with Dr. Sharon Walmsley at the University Health Network, focused on integrating comprehensive geriatric assessment into HIV care for older adults. Her research centers on improving health systems, quality of care, and patient-centered aging experiences for older adults living with HIV using implementation science and community co-design approaches. Following Luxey, we'll hear from Carolann Murray, who is a registered physiotherapist with more than 36 years of experience working in rehabilitation with complex populations across Canada and New Zealand. For the past 7.5 years, she's been a physiotherapist for the outpatient clinical program at Casey House Hospital in Toronto, where she works as part of an interdisciplinary team supporting people living with or at risk of HIV. Her work focuses on improving quality of life through movement and exercise, and she has helped develop several innovative programs, including falls prevention, chronic pain self-management, and community exercise initiatives. Carolann has also contributed to research exploring physiotherapy, exercise, and disability among people living with HIV. So without further ado, I'm going to pass it on to Luxey.
Okay, great. Thank you for that kind introduction. Hello, everybody. My name is Dr. Sirisegaram. Dr. Luxey is fine. And today I'll be talking about HIV and aging. My goal is to make the golden years extra shiny. Today we'll delve into the intersection of HIV and aging within the Canadian healthcare landscape. Our focus will be on primarily epidemiological trends, the application of something called the comprehensive geriatric assessment, which is what I do in my clinic in HIV care, and practical strategies to enhance patient care. So for a quick outline today, we'll be examining the Canadian epidemiological data in HIV and aging. Following this, we'll explore the biological interplay between HIV and the aging processes. We're going to really focus on the 5Ms framework, its relevance, and the role of the comprehensive geriatric assessment in optimizing care. And the 5Ms approach is something that we know and love as geriatricians, and I apply it to older adults living with HIV. And then finally, we'll address some clinical considerations and future directions pertinent to all of our practices. Essentially, there is some upward trajectory of HIV when it comes to aging. As of 2020, approximately 50% of people living with HIV in Canada are aged 50 and older. 1 in 5 new HIV diagnoses in Canada occur amongst individuals who are 50 plus. And between 2008 to 2017, the proportion of the newly diagnosed HIV cases in Canada has increased from 15% to 22.8%. So there is an increase there. The median age in Canada is expected to surpass 65 within the next decade. So, what does this all tell us? This tells us that the aging demographic of older adults living with HIV in Canada underscores the necessity for age-specific care strategies. And the notable rise in new diagnoses amongst older adults highlights the importance of targeted prevention and early intervention efforts. So, why is this happening, right? Why are we seeing this accelerated aging when we're talking about older adults living with HIV? And there are multiple theories out there. Personally, I think it's a combination of all of the above. But it's important to note that aging while living with HIV is not equal to typical aging. There's persistent immune activation, even on ART, which accelerates age-related decline. And this is postulated to be thought to be from a number of different reasons. One is immune dysfunction. So there's an early loss of naive T cells. There's exhausted CD8 plus cells and T cells and sustained inflammation. This sustained inflammation is also nicknamed inflammaging, and it's shown to have biomarkers such as IL-6 and TNF alpha, which are associated with increased cardiovascular disease, neurocognitive impairment, and frailty. So very much what I see in my older adults. There's also some theories about epigenetics and metabolism, specifically with mitochondrial dysfunction and oxidative stress that causes some multimorbidity. Multimorbidity simply means you have more than one disease. And so the more diseases that you have, the more complex you get. And that's really what they think is driving this multimorbidity we're seeing in our older adults. And lastly, the clinical impact here. So older adults living with HIV are developing geriatric syndromes, which means diseases that happen as you age faster. So the question now is, now that we know that this cohort is aging and aging at an accelerated rate, how do we apply what we know about geriatric medicine to help this population? So I'm going to introduce you all to the 5 M's of geriatrics. In geriatric medicine, this is our bread and butter, and it essentially provides a structured framework for addressing aging-related concerns in older adults living with HIV. And applying this model helps optimize care and improve quality of life. So the first M is mind. Specifically here, we're going to, and you go like this with your 5 M's. It's a little thing to help you remember. But your first one is mind. So cognitive impairment is common in older adults living with HIV, even with well-controlled disease. And we know that there's already something called HIV-associated neurocognitive disorder, which can range from mild cognitive decline to dementia. But more and more, we're finding that this inflammation, vascular risk, and neurotoxicity also contributes to neurocognitive impairment that we see. We also have mobility. So older adults experience more frailty, sarcopenia, which is a fancy way of saying less muscle, and osteoporosis, which is thinning of the bone earlier. The reasons for this are because ART, especially older regimens, accelerated bone loss, increasing fracture risk. We also have polypharmacy. So when someone is on more than 5 medications, we know that they tend to fall a bit more. So they will fall and fracture more often. And so this really highlights that strength and balance assessments should be routine with referrals to physiotherapy as needed. So that's a nice nod to our next session here. The next is medications. So multimorbidity, or having a lot of different diseases at once, creates a high risk of drug-drug interaction and adverse events, right? You're on tons of different medications, each for a different disease, but they can interact with each other too. Polypharmacy is very common. So medication reconciliation, i.e. looking at all of the meds that you're on, including ones that you're taking over the counter, and deprescribing, asking your physicians for deprescribing of this should be key. It's also important to note for our practitioners out here that we do have the CYP450, which is a special enzyme which helps metabolize our ART treatments, also increase risks of other medications like anticoagulants and psychotropics. So bearing that in mind. The fourth M is multi-complexity. We know that a higher rate of multimorbidity is prevalent in this population, but we also know that there's complex social determinants at health at play here. So for the multimorbidity, often we see cardiovascular disease, diabetes, chronic kidney disease, and mental health conditions are more prevalent. But when you take that and you also take that often these older adults living with HIV are socially isolated, meaning that they don't have many people to support them around them. Stigma and financial instability really impact their adherence and well-being. And so it's impossible to say you only have CKD and diabetes and you're complicated. You always have to look at the whole picture. So you have CKD and diabetes and you have no one to help you figure out how to give your insulin, or you don't know where to go to get supports for if you need, if you're having peripheral neuropathy because you're socially isolated. These things all kind of balance out, and you need to make sure that you're taking a look at the whole person. And the fifth one is the one that's near and dearest to my heart, which is what matters most. And as older adults living with HIV age, their goals and care should be aligned with their own goals and priorities. This means advanced care planning needs to be happening earlier and more often. Also, symptom management and palliative care discussions. This means things like power of attorney need to be discussed. Things like if you were to go to hospital, and you weren't able to make decisions, who would that be? Who would you want there for you? Need to be discussed. And what level of code status you would want need to be discussed. Quality of life, independence, and social supports are really critical for long-term care planning, and shared decision-making ensures that medical care aligns really with the patient values. So the goal here is that by integrating the 5 M's into HIV care, we can shift from this disease focus approach that we've had for so long to a comprehensive patient-centered model that addresses aging related needs and improves long-term outcomes. So to do this and to systematically address each of those domains, we use something called the Comprehensive Geriatric Assessment, or the CGA. So the key components of the comprehensive geriatric assessment really looks at these 7 areas, and you'll see that the 5 M's are embedded within these 7 areas. The first is functional status. So this is really looking at how well an individual is functioning in society. And you can look at, and that's called their independent activities of daily living. And then you can also look at their basic activities of daily living. So how well they're functioning on their own. And this helps identify deficits in daily functioning and guides interventions to enhance independence. So really what this is saying is, yes, someone can be medically complicated, but if they're unable to pay their bills because they're losing track of their bills, this is a good way to sort of figure out, oh, okay, you're losing that ability to function. You're losing that ability to do complex tasks like pay bills or do your taxes. Maybe we should step in and intervene here and see if there's anything reversible so that we can help preserve that function. Which brings me to cognitive function. Cognitive function and cognitive testing is extremely prevalent, and we use it all the time. There's something called the MoCA that we can use. There's also the HIV dementia scale, but this is a little bit more nuanced than just using a MoCA. A lot of the times, there also are different levels of education, if English is a second language, that can impact your cognitive testing. So sending them to a geriatrician to do their cognitive testing is often really helpful for those subtle nuances. Mental health is also a part of the the comprehensive geriatric assessment. And really here, it's making sure that we scan for that mood component, by using validated tools. So we use something called the Patient Health Questionnaire, called the PHQ-9, to help screen for rates of depression. Also speaking about substance use and early screening about using illicit substances are key here. The next is polypharmacy and deprescribing. There are tools that you can use for polypharmacy and deprescribing. The medication appropriate index is one of them. There's a stop-start criteria, but there's also colleagues that you can ask for. Geriatricians are really great with deprescribing medications. We're pretty comfortable with it. So if you're on 5 or more medications and unsure and unclear as to why, you can always ask for your medication list to be looked at. Falls and bone health is also a huge part of what we do. The assessment tools that we use are the time up and go, but we also use the FRAX score for fracture risk because we know about the higher osteoporosis fracture risks in older adults living with HIV, and we use mobility assessments to guide fall prevention. For social determinants and caregiver support, there are some tools that we can use here called the Social Vulnerability Index and Caregiver Burden Scales. And this really addresses housing instability and stigma, as well as lack of caregiver support and helping get those supports in place so that these individuals can age well. And lastly is that advanced care planning piece, that what matters most. Really, it's looking to using tools like respecting choices tools and serious illness conversation guides, or merely just planting the seed about, asking, what does your future look like? What would you like it to look like? And just start the conversation about future planning is really key here. So when we took this comprehensive geriatric assessment that I just described, as well as the 5 M's, and we applied it to older adults living with HIV, we really found a couple of very interesting things that happen. Frailty is a big one. So frailty occurs in 11 to 30% of older adults living with HIV, about 2 times higher than those living without. Cognitive impairment as well affects about 1 in 4 to 1 in 2 older adults living with HIV. Polypharmacy is also a huge, I would say, issue in this population as well. So over 50% take greater than five or more medications, and that's not including your ART. So this really shows that there is an increased risk of drug-drug interactions that can occur. Also, with social isolation and depression, there have been studies that have shown that it's 1.5 times higher risk than the aging population. So it's really important that we do talk about that, what matters most piece, and social isolation. For bone and falls health, older adults living with HIV exhibit about 2 to 4 times higher prevalence of osteopenia, which is thinning of bones, and osteoporosis, which is pathologic thinning of bones. And that their fracture risk is about 1.5 to 2 times higher amongst older adults living with HIV. So the CGA helps us sort of tease apart these more subtle findings that you wouldn't necessarily do with a quicker assessment. So it's important to note that in implementing a comprehensive geriatric in HIV clinics does not replace HIV care. I do not do anything with any type of ART really. I simply enhance care by addressing all the other accoutrement that happens with aging. And simple tools can really be embedded in routine visits without significantly increasing workload. And a multidisciplinary team is really essential here for effective intervention. So when I go into the 5 M's now, and I'm going to talk about each one. So the first one is going to be mind. And really here, this is more for practitioners, but it's more about if you're suspicious of cognitive decline. And so really you're going to say, are the viral loads going up? Are there missed appointments? Is there decreased understanding of what's happening in the appointment? And another thing that you can ask are caregivers. They're a really great source to ask about cognitive changes. And really you ask, are there any changes in thinking? And just a heads up for things to order, an MRI is preferred here, along with basic dementia blood work. So B12, TSH, A1C, lipids, and routine blood work. And of course, always feel free to consult geriatrics for cognitive impairment here. For mobility, and I'm sure Carolann will be going into this much more in depth, a nice screening question to ask or to raise to your practitioners are, hey, I've had a fall. And for practitioners, it's asking if you've had any falls in the last year. A big one is making sure that you have a bone mineral density on file for older adults, even if there are no falls, and ensure vitamin D levels are adequate. Additionally, you want to do a medication review, looking for FRIDs, also known as falls risk increasing drugs. And you can see those here. So I like to say my Z drugs, so benzodiazepines, trazodone, those types of drugs are ones that can really increase falls, but sleeping pills, antidepressants, and opioids can also really increase your risk of falls, along with the other medications listed there. Just because they're listed, though, doesn't mean they're responsible for your falls. It just means that they should maybe be looked at a little bit more carefully, and a discussion should be had about their risk benefit. As we all know, when you age, your body changes and your way that you metabolize things change. So some people will say, well, I've been on this antipsychotic or antidepressant for 40 years. Why would I stop now? But it's important to note that your body has changed. So maybe the way that you metabolize those drugs have changed. So it's important to always be looking at your medication list with a keen eye and knowing why you're prescribed everything that you're prescribed. Again, referring it to a geriatrician is key here. For medications, again, you can use the FRIDs as mentioned there. There's also a useful tool called the Beers criteria that the American Geriatric Society has released. So you can help use that to guide you. Polypharmacy is more than five or more meds, not including ART. So refer to geriatrics if you need medication tapers. And in Ontario, there's a wonderful program that's virtual called Geri MedRisk. Well, they'll look at all of the drugs that were ever prescribed on Connecting Ontario and provide you the most detailed consult about the drugs and what they suggest to be deprescribed or not. The next M is mood. Social isolation, as we discussed, is a significant issue, as well as depression and anxiety. Early referrals to psychiatry and to social work are key, and referral to geriatrics as well for access to other programs. And the last really is what matters most here. Goals of care discussion need to be happening often and early. Power of attorney selection and process need to be talked about and discussed. Social work referrals need to be placed for aging well while in place, and a geriatrics referral. This is just for the practitioners in the room. For general geriatrics, it's about a 7-month wait time through UHN and Sinai. For my clinic, it's about a 1-month wait time, but there will be a pause for about a year as I'm going on leave. And there's also the independence at home. So this is for patients who are more homebound. They can't leave the home for a variety of reasons, be it disability, cognitive impairment. They will also go and see your patients in the home, and they follow for about 3 months, and they have about a 2-month wait time right now. So in conclusion, HIV and aging is a growing issue requiring multidisciplinary care. So a combination of infectious disease, geriatrics, family care doctors, as well as physiotherapists, occupational therapists, and social workers. The geriatric frameworks, i.e. the 5M, can really optimize HIV care for older adults, and addressing things like multimorbidity, polypharmacy, and social factors is really key. Future research is needed to improve outcomes and develop co-models of care, but integration is feasible, impactful, and necessary for this aging population. For the practitioners in the room, feel free to refer over to me. So I see patients who are 65 plus or 50 plus with cognitive concerns in particular. That's my email, and you can book via the immunodeficiency clinic. And here are my references for everything I talked about today.
Thank you so much, Dr. Luxey. So we're going to go ahead and move on with Carolann Murray.
Okay, thank you so much for inviting me to speak today. I am, as Diana mentioned, the physiotherapist at Casey House. And today I'd like to speak to you about using my work at Casey House as an example of rehabilitation for people living and aging with HIV. Hang on, I just have to hide this. So a lot of what I say is very similar to what was just mentioned, so it's going to fit well. So you might be wondering what is contributing to deficits in HIV. Today we're going to focus mostly on physical deficits. HIV severity is one of the first things we have to consider. So a worse viral suppression, lower T cells is often associated with worse physical function. Chronic inflammation in the brain and the body leads to mitochondrial damage with the chronic inflammation and oxidative stress that we see. Central nervous system damage can lead to balance deficits and cognitive impairments, such as HIV-associated neurocognitive disorder, or HAND, and higher rates of vestibular dysfunction, which is also something that I can manage as a physiotherapist. HIV related deficits are also associated with certain comorbidities that tend to occur earlier in this population, on average 10 years earlier, and with more frequency than the HIV negative population. So some examples of the comorbidities that I see here at my practice is peripheral neuropathy, chronic pain, osteopenia, osteoporosis, diabetes, lung disease, asthma, cancers, anal, liver, cervical, and Hodgkin's lymphoma, stroke, frailty, and mental health issues. And in addition to those comorbidities, I also see in my clinical practice much higher rates of osteoarthritis and avascular necrosis as well. So physical deficits can be quite common in people living with HIV and aging with HIV. As Dr. Luxey mentioned, sarcopenia is one of the deficits we see, which is basically reduction in size and function of muscle. 20% of middle-aged people living with HIV have sarcopenia, compared to about 4% in the HIV negative population. 30% of middle-aged people living with HIV fell once or more in the previous year. And people living with HIV tend to demonstrate impaired function with sit to stand and impaired balance, specifically the standing on one leg test. These deficits are happening in many people with undetectable viral loads. Other physical deficits: decreased aerobic capacity. People living with HIV of all ages have reduced aerobic capacity compared to age-matched controls. This can have significant implications for activities of daily living and functional independence. Walking performance limitations is another deficit I see very commonly, and of course, frailty. So the definition of frailty is a state of increased vulnerability among people of the same age, which increases risk of falls, disability, dependency, hospitalization, institutionalization, and death. Research suggests a higher relationship between HIV and an early progression to frailty. Good news, though, frailty can be reversible. Outcome measures, so HIV and Aging Clinic, that is needed, I think, here at Casey House. We don't have a geriatrician, which is very unfortunate, but we do have hopefully more primary care coming, and potentially nurse practitioner involvement, because I still really feel that frailty, especially, and also cognitive decline, are very underaddressed, especially here at Casey House. And that's something that is a bit of a gap for us. Some outcome measures that could be used in an HIV and Aging Clinic: the clinical frailty scale. I use the short physical performance battery, or the SPPB, and that looks at gait speed. It looks at 5 times sit to stand. A timed up and go is another measurement that I use. It really depends on the client. There's several different walking tests. We can customize it to what the client presents with. So what can rehabilitation do for people living with HIV? So as people are aging, living longer, the focus shifts from quantity of life to quality of life, and that's what rehabilitation can help with. The actual definition of rehab is a dynamic process including all prevention and/or treatment activities and/or services that address body impairments, activity limitations, and participation restrictions for an individual. So rehab can help with muscle weakness and sarcopenia, mobility and balance deficits, chronic pain, comorbidities associated with HIV infection, decreased cardiorespiratory capacity, side effects of medications, not just your HIV medications, but also medications from cancer treatments, atypical antipsychotics. And rehab can certainly increase physical activity levels. Benefits of exercise for people living with HIV. It's not really different than the other population that are negative, but improves balance, reduces fatigue, can improve cardiovascular fitness. There's been some research to show that aerobic exercise can improve cardiovascular fitness that people living with HIV can benefit from more high intensity aerobic exercise than the HIV negative population. So it's definitely important for people to get out and exercise at a higher intensity. Physical activities associated with better cognitive function, resisted training, helps prevent muscle wasting, and can help with managing osteoporosis. And then, of course, group exercise has many social benefits, primarily a decrease in social isolation. During the pandemic, I ran one of my exercise classes virtually, and the number one reported benefit from all the clients who participated was decreased social isolation. And exercise and a healthy lifestyle can also help with liver health as well. So just to summarize, how can PT help? We can manage and help people with energy conservation. The reason I mention that is the number one symptom that people report when they're living with HIV is actually fatigue. So energy conservation can be really important. Pain management, over 2/3 of my caseload is chronic pain. Gait aid prescription, and of course, falls prevention, especially as people age and if they're frail. Exercise prescription is a very large area of practice for a physiotherapist. Aerobic exercise, resistance training, and balance training. For the HIV population, when I'm doing exercise prescription, I have to look at guidelines related to some of the comorbidities. So not just HIV, but do they have heart conditions? Do they have osteoporosis? So it gets a bit complicated when the clients I work with have so many comorbidities. Other PT interventions, education, really important. We spend a lot of time educating clients on chronic pain, self-management techniques. As a physiotherapist, I manage musculoskeletal issues, cardiorespiratory, neurological conditions, and vestibular disorders. And I see all of that in my practice here at Casey House. Sometimes in one patient or one client. Advocacy is really important as well. Rehab isn't considered a standard of care for people living with HIV, so PTs often have to advocate for clients, especially the marginalized clients, to get the equipment and the services they need, to get funding for assisted devices, to get an accessible parking permit. We have a comfort fund at Casey House, so we can provide some small pieces of equipment for clients that isn't covered by the government, which can be very helpful. And also collaborating on advocating for external partnerships. We partnered with Pain BC and managed to bring their well-funded and well-developed self-management program for chronic pain, a group called Making Sense of Pain here at Casey House. And as part of a clinical intervention, we also have to take into consideration trauma-informed care approach. There's higher rates of PTSD and trauma among people living with HIV. So building relationships based on respect, trust, and safety, framing questions and statements with empathy and being non-judgmental, watch for and try to reduce triggers. I had one client who was triggered by blue TheraBand because it looked similar to a tourniquet that he used to use when he was using substances. So I'd have to make sure that when he came into the gym, there was no blue TheraBand around anywhere. So just being observant and ensuring that you try to reduce triggers. Make sure the client is comfortable, check in with them frequently, and continually explain what is happening. Makes a huge difference. For our clients that use substances, we have a harm reduction approach we use. We meet people where they're at. We work to reduce risk to their health without judgment. We provide support to use drugs safely. Casey House has both an inpatient and an outpatient supervised consumption service site. Both SCS units are for supervised injection and supervised inhalation. Okay, so that's Casey House. Very nice building. The outpatient services at Casey House, it's a goal-focused health services for people living with HIV or people at high risk for HIV infection. We strive to aid in decreased hospitalization, health stabilization, navigation of health systems, improve wellness, functionality, mobility, quality of life, healthy aging with HIV. That's where I come into play. And my colleague on inpatients, Manjeet, and my OT colleague on inpatients, Bobby, as well. Pain management, harm reduction, treatment adherence, improved access to food. We have a lunch program that runs Monday to Friday, 12 to 2, and that is a picture of our dining room there. Each client has access to a 2-week respite on our inpatient unit. We have a 14-bed inpatient unit. We also do HIV testing, STI testing, and we have a Cabenuva clinic. The outpatient services team, we, again, need to have a large multidisciplinary or interprofessional team to manage the clients that we see here. We have a mental health clinician, we have a social worker, we have 2 rec therapists who really work on decreasing social isolation for our clients. We have a part-time registered massage therapist, 4 registered nurses, 4 social service workers, 1 registered physio, myself, 2.5 harm reduction workers, a program assistant, and we have a consulting psychiatrist as well. Physiotherapy at Casey House consists of one-on-one physio assessments and treatments across both inpatient and outpatient departments, access to time-limited physiotherapy group programming, and progression and reintegration into community programs. So this is the gym. It looks quite big in this picture. It's actually not as big. It's mainly because of how they took it with a fisheye lens. But anyway, it's a very well-equipped gym and very calm, inviting atmosphere. I run 2 main exercise classes out of that PT gym. The first one, Steady on Your Feet, is a falls prevention class. So we focus on leg strengthening, balance training, education. So education, teaching someone how to get up from a fall, teaching them how to decrease their falls risk at home. So getting rid of scatter rugs, getting rid of cords they could trip over. Mobility device assessment. We have a seating and mobility clinic here for our clients, so we can manage any mobility device for our clients through that. This class is for clients who have had 1 fall or more in the past year, or who we deem at high risk of falling. Some of the outcome measures that I use at the start and finish of this exercise class, the Berg Balance Scale, 5 times sit to stand, timed up and go, and there can be other ones depending on the client. The other class that I lead is a circuit class. It's for clients who are aging with HIV, and the focus is on resistance and aerobic exercise, balance training, and education for living with HIV and aging. So we'll have education topics on benefits of exercise, sleep hygiene, nutrition, medications, things people want to know about their ARVs or antiretrovirals or other medications. We ask clients for input in terms of what topics they'd like to hear about. And for this class, I use 6-minute walk test, 5 times sit to stand test, 1 rep max strength test. So considerations for rehab and exercise in this population, not a one-size-fits-all. Episodic health equals episodic exercise. The sec here. So this study was 14 clients from Casey House were asked about their readiness to participate in exercise. And it's very much a fluid and dynamic thing that sort of ebbs and flows with the severity of their HIV comorbidities, their mental health. And there was also some other social determinants of health, like social supports, their perceptions and beliefs, their experience with exercise, and accessibility, both financially and physical accessibility, had an impact on how ready they were to exercise. So we try to keep our exercise programs here very low barrier. And we understand if someone has to take a break from the exercise program for a while because they're not feeling well, and we welcome them back when they're feeling better. We have very nice facilities here, and we try, and there's no cost. So accessibility is pretty high if they can attend Casey House to be able to engage in exercise. Those are some of my resources, and my references are available on request. So take-home messages. So people living with HIV have complex physical, psychological, and cognitive impairments. HIV is episodic and multisystemic in nature. And there is a gap in care for people aging with HIV, which needs to be addressed. It is getting better addressed. I'm really happy there's HIV and aging clinics. But I still think that screening and early treatment for people who are starting to become pre-frail or frail could be better. And the cognitive decline, I think, could still be better addressed. And thank you very much.